Hello everyone. Today we will be talking about LNG-IUS. What is it? Levonorgestrel-Releasing Intrauterine System. Why I have chosen this topic to talk today? Because if we start talking about pharmacology in gynecology, it is all about hormones. And in many cases of AUB, we are talking about LNG-IUS. In contraception, we are talking about LNG-IUS. What is LNG-IUS and why it is S, not D, right? It contains progesterone, which is levonorgestrel. So it is a preparation containing progesterone, and what effect progesterone has on uterus we have already studied in our menstrual cycle lecture as well as AUB lectures, that any endometrium which is estrogen primed, in that case if we supply progesterone to the body, it gives a quiescent effect. It relaxes as well as stops the bleeding. So this has a quiescent effect on the endometrium and we want that effect. This is something which is very similar to the copper T devices which we used in contraception. Why I am talking about copper T? Because copper T was an earlier version and almost everyone knew about it. What is copper T? It is a small T-shaped device which is kept inside the uterus for the purpose of contraception. But here it is not copper which is on the device, it is levonorgestrel. And it is a system because it has a central reservoir which releases it slowly, slowly, slowly. So some people call it as device, but mostly it is called as system. So levonorgestrel releasing intrauterine system. Now we will study about it systematically. It will cover your concepts, your theory lectures, your MCQs, Viva also. So what is LNG-IUS? If somebody asks you what is LNG-IUS, mainly it was devised as a LARC. What is LARC? Long acting reversible contraceptive. So coming to the new generation of contraceptives where we want a one-time installation and a long-time reversible action, then subdermal implants and LNG-IUS were the option. So earlier, mainly it was a reversible contraceptive. So long-acting reversible contraceptive, it releases levonorgestrel directly into the uterine cavity and provides a strong local progesterogenic effect used for contraception and gynecological conditions. That's why I am taking it as a separate lecture because it has both the uses. It is a contraceptive as well as a device where we can control bleeding in gynecological conditions where basically AOB has no defined characteristics. Now, what is the composition and structure? It is a T-shaped polyethylene intrauterine device. Somehow it looks like this. These are the threads. This is the central structure and these are the other brands. And the most common trade name selling of LNG-IUS is Mirena. So if we talk about Mirena, the structure looks somewhat like this, right? And the other names are Emily and many other names. It is available as Mirena and Emily, but there are 4 or 5 other trade names also. So this is a T-shaped polyethylene intrauterine device having a central cylinder reservoir containing levonorgestrel. In case of Mirena or the 5-year IUS, it is 52 milligram total drug dose, which is released at a rate of 20 microgram per day initially for the first year, and then it decreases slowly and slowly. Generally, it is valid for 5 years. So this central reservoir will contain a total of 52 milligram of levonorgestrel, which it releases daily 20 microgram per day. Rate controlling membrane is here, which regulates the hormone release, and the removal threads are attached to this vertical stem. So this is the structure and the composition of the device. This is a general picture. A Mirena does not look like this, but just for your understanding, there is a central reservoir and there are horizontal, this thing which are a bit T-shaped. Vertical stem contains LNG reservoir and the horizontal arms are made to stabilize the device. Some teacher may ask you this question in your viva, that if the drug is in the central thing, then what is the use of the horizontal arms? Horizontal arms are there to stabilize the device inside the uterine cavity, somewhat like this. These are the anchors, right? Removal threads extend out from the cervix. Now, what is the mechanism of action? Very important. Why it could be used as a contraceptive as well as to control bleeding? Endometrial suppression. Most common, most important effect of LNG-IUS, because it has anti-proliferative effect. We know, we have read, this is the basic of gynecology, that estrogen has a proliferative effect. It starts proliferating everything, the glands, the stroma and everything. Whereas progesterone has a secretory effect. It controls the things. So because of the anti-proliferative action, it suppresses entry. There is a local uterine action, so it has minimal side effects. So in those high-risk patients where oral hormones are contraindicated and may cause further trouble, then this is very important because it releases the progesterone inside the cavity and it has minimal systemic effects. So it is very beneficial. Ovulation normally continues. Normally what happens in contraception, if we are giving combined oral contraceptive pills to a patient, the main idea is to suppress the ovulation by suppressing the pituitary. But here, our main idea is to suppress the endometrium, to make the endometrium hostile for implantation, as well as thickening of the cervical mucus, so that the sperm entry is hampered. Take home message from this is that we have designed something where we have the action of progesterone only pills as well as an intrauterine device as well as only local action. So we want to take advantage of everything, progesterone only pills as well as IUD as well as local effect. So what are the indications? As a contraceptive, we have already talked. Idiopathic menorrhagia, very important. Idiopathic menorrhagia. Go back to our AUB lecture series and try to understand. Called as palm coin classification, where we try to find out the reason of heavy bleeding to a patient. If in that case the patient lies in this I category where there is no further reason, there was no leiomyoma, there was no adenomyosis, there was nothing, there was no polyp. So if we keep it inside, it will cause endometrial suppression and less bleeding. In cases of idiopathic menorrhagia, the effect generally lasts for 5 years. Dysmenorrhea and endometrial protection in selected cases. In selected cases of adenomyosis as well as part of a LARC, long-acting reversible contraception. As a contraceptive, if you are using this, then the effect lasts for 8 years. So if the patient comes to you for the purpose of contraception, we can counsel her that you will have to change it after 8 years. But if she is coming for the complaint of heavy bleeding, then we will have to change it after 5 years. This is very important. Selected cases of adenomyosis where the size is less than 10 centimeter. Small fibroids which are not distorting the cavity. Why are these 2 points important? After doing a transvaginal ultrasound, what we see is, remember I have told you, you have to see the EEC, endometrial in the AUB lectures. So you look at the endometrium and decide whether there is some polyp or not. If the total length is not more than 10 centimeter, that is in cases of early adenomyosis, as well as there are some leiomyomas here or here which are not distorting the cavity at all, then we can actually put the LNG-IUS here, work on the endometrium, and slowly it shrinks and the bleeding decreases. In cases of endometriosis also, it decreases dysmenorrhea, because our idea in endometriosis also is to decrease the frequency as well as amount of menstruation. In toto, in your theory, where you have read that we need to give continuous progesterones in 1, 2, 3 options, then in all options we can use LNG-IUS. Contraindications. See, I have told you LNG-IUS contains progesterone. So every contraindication where progesterone is contraindicated, where generally we will have to be very careful while using LNG-IUS. As such, it has minimal side effects, minimal systemic side effects, but we have to see. Plus, all the contraindications of a copper T. So contraindications, there's a long list of contraindications, but these are not absolute. Known or suspected pregnancy is an absolute contraindication for any intrauterine device or any hormonal thing. If there is a pregnancy in this patient, we cannot keep it inside. Current or recurrent pelvic inflammatory disease. See, if you have read contraception, so any intrauterine procedure, any intrauterine insertion is contraindicated in cases of pregnancy as well as pelvic inflammatory disease. You may actually flare up the disease and end up in trouble, or you may disturb that pregnancy. Lower genital tract infections. Before inserting anything, you should be very clear that there is no infection in the way. Postpartum endometritis. Infection, inflammation at any place, we don't go for insertion of any intrauterine device. Undiagnosed abnormal uterine bleeding. This word is important. What is undiagnosed? The patient came to you and you put a LNG-IUS. This is not correct. First, you will have to go for all investigations, basic investigations, to know that yes, is a case of idiopathic AUB. Only in that case we can give LNG-IUS. Otherwise, if you put in undiagnosed, I don't know whether it could be a leiomyoma or there could be hyperplasia, there could be cancerous changes. So first rule out all those things. Uterine anomalies including fibroids if they are distorting the cavity. Take home messages: before insertion you should be very clear that the cavity is a normal size uterine cavity. It is normal. It is not like this also. Any bicornuate uterus, any uterine diadelphys, you cannot keep a Mirena here and leave the other thing. If there is a big fibroid here, it is an absolute contraindication. You cannot keep anything inside. Uterine or cervical malignancy. Malignancy of any sort. You cannot keep any intrauterine device. You cannot give any hormonal supplement. Known or suspected progesterone dependent neoplasia, including breast cancer. These are relative contraindications. Breast cancer, any cancer which can increase after giving progesterone, don't go for insertion of LNG-IUS. Other are cervicitis. So how will you remember all these? Just think about the hormonal problems, think about intrauterine thing, and then the things will start coming. Like we ruled out pregnancy, then PID, any sort of infection, then cervicitis, endometritis, fibroid, malignancy. These are all those. Cervical dysplasia. What is dysplasia? Early changes in the cell structure which may lead to malignancy. active liver disease or dysfunction, because it is a progesterone containing device. None of them are absolute contraindications. The earlier page were absolute. These are not absolute. If the liver function is normal and there are minimal systemic side effects, we can monitor during the whole thing. Benign or malignant liver tumors. Septic 3 months, that is 12 weeks. Any sort of sepsis is a big no for any intrauterine intervention. Hypersensitivity. This is applicable to almost all the drugs, all the things, that allergy or hypersensitivity to anything, be it be levonorgestrel or any other ingredient in the formulation. So pregnancy, always rule out pregnancy. I always emphasize, whether it is AUB or something else, always rule out pregnancy. So pregnancy should not be there. Anything should not be sitting inside the endometrial cavity, like there should be no polyp, there should be no fibroid, no infection, no PID, no cervicitis, no endometritis, no septic abortion. And then there should be no dysplasia, no malignancy, no hormone dependent malignancy, no breast cancer, nothing. Contraindications. Bacterial endocarditis. We are continuing our contraindications, right? Bacterial endocarditis is not an absolute contraindication. Earlier, it was thought that any intrauterine device should not be kept in this case of this, but this is under study. Some ACOG guidelines say that yes, we can put it. So we have to be very, very wary. But any immunodeficiency affecting blood, like leukemias, recent trophoblastic disease. What is this? Any kind of vesicular mole, or we call it as hydatiform mole, or GTT, gestational trophoblastic disease, where HCG levels are still elevated. We know that if we have studied the vesicular mole, that till the HCG levels are down for a long time, we cannot use any hormonal contraceptive. As well as intrauterine device, it can lead to perforation. A previously inserted IUD that has not been removed. The patient already has an IUD inside and she comes to you for some other complaint and you try to insert. So always first rule out that the cavity is vacant, the cavity is normal. And pelvic infections, increased susceptibility to pelvic infections. So you cannot remember this whole list. Just remember pregnancy, PID, all sorts of infection, malignancy, and anything which is flared up by hormones. That's it. Now, precautions. These are all things that are generally asked in vivas and in your clinical practice also, that what all you will explain to the patient. It does not protect against STIs. It is applicable to any non-barrier contraceptive, because STIs are prevented by barrier contraceptive. Why? Because only barrier contraceptive can prevent an organism to travel from the male partner to the female and vice versa. It will not prevent this. Cigarette smoking. Always ask the history of smoking, because it increases the incidence of serious adverse effects of the heart and blood vessels. Uterine perforation may occur. This has to be told to the patient beforehand, that this can be possible. And it is not suitable as a post-coital contraceptive. Why? Because I told you people take it as a copper T also. Copper T can be used as a post-coital contraceptive, but this cannot be used because the mechanism of action is altogether different. Now, dose. We have already talked. If you are using it as a contraceptive, if the patient asks you that I am going for this as a contraceptive, then it will be changed after 8 years. If you are using it for the control of heavy bleeding in AUB, then it will be changed after 5 years. 8585. Now, administration. This part was all theory, that what indications you should know, what contraindications you should know, what you should explain to the patient. Now comes the point, now you want to insert. Everything is done. Medical examination before insertion is absolutely mandatory. Inform the efficacy, the risk, and the side effects, which we have already talked about. A thorough history of the patient and physical examination should be done, because there are many things which patient may not think that that is important, but that is important for us, like history of smoking, any history of vascular thromboembolism in the patient or in the family, like this. Estimation of blood pressure. Sometimes there is an increase in blood pressure after administration of LNG-IUS. Although it is very, very rare, but it may happen. So we should have a baseline of the patient, that the earlier blood pressure was this and after this is this. Examination of breast for any sort of tumors, liver and pelvic organs, which we have already talked about. Cervical smear, pap smear should be performed. This is also called as pap smear. Go for a pap smear. Why? See, everything is interrelated. We have already talked in contraindications that any sort of dysplasia or malignancy is a big contraindication for LNG-IUS. So first, you should be very, very clear that the patient is not having any dysplasia, any CIN, any carcinoma, any systemic disease, any breast cancer, any liver problems. That's why we are doing a baseline checkup. Pregnancy and STI should be excluded. Pregnancy is a big no. First absolute contraindication was pregnancy. Always rule out a pregnancy. And STI, definitely it is not going to protect, but you will have to see during the insertion there should be no local infection. Any genital infections, if present, then first treat them and then take up the patient for insertion. What is the timing of insertion? This is important, because what we are doing, why, if we are inserting it as a contraceptive, then first 7 days of the menstrual cycle. Why? This is applicable to every contraceptive, because in first 7 days of the menstrual cycle we are pretty sure that the patient is not pregnant, and pregnancy is an absolute contraindication. But if the patient comes at some other time of the cycle and the patient and the healthcare professional is absolutely certain that she is not pregnant, then we can put it at any time of the cycle, but we will have to ask the patient to abstain from vaginal intercourse for coming 7 days, or she should use a barrier contraceptive, because till 7 days she is still not protected. So better to insert in the first 7 days, but it can be inserted at any other time if you are pretty sure that the patient is not pregnant. And exclude any endometrial pathology before insertion, that we have talked time and again, that the endometrial cavity should be absolutely normal. Now, administration. The other thing of administration is that the position of the uterus and the size of the uterine cavity should be determined. We have counseled the patient, we have told everything, we have done all baseline investigations, everything is normal. Now the patient is on the table and you are doing the insertion. First of all, make the patient relax, talk to the patient in the presence of a nurse. Always keep a female chaperone whenever you are doing any gynae examination, and make the patient comfortable, and then do your pervaginal examination. Why? Because you want to know what is the position and the size of the uterus. In your bimanual examination, whether the uterus is anteverted, retroverted, what is the size, just confirm. We have talked within 7 days of the onset of the menstruation, and we should be reasonably sure that the patient is not pregnant. I am repeating it again and again. If the patient had some second trimester abortion, then it should not be done up to 6 weeks of the abortion. Or she wants to do it in a postpartum period, then minimum 6 weeks and maximum 12 weeks we need to wait. Our idea is that the uterine size should not uterine cavity should be normal. So after a second trimester abortion, uterus generally goes to the normal size up to 6 weeks. But after a full term vaginal delivery, it takes minimum 6 weeks, maximum 12 weeks. So before insertion, be careful that the size is not too much large. It is not more than 10 centimeter and the endometrial cavity is perfectly normal. Now, this LNG IUD, I will show you a picture. Yeah. LNG IUD, specifically if we talk about Mirena, it is given in a sterile package. See, this is a package and we have flipped over the cover. So it comes in a sterile package and we need to open it just before the insertion. And should be opened just before insertion. It is pre-sterilized with ethylene dioxide and we do not need to re-sterilize. This is a very, very common Viva question. Many times the examiner asks you, what will you do? How will you sterilize? It is not needed. It is pre-sterilized. It is packed. So now the patient is on the table. You have done a vaginal examination and you are ready for the insertion. Have a good light source. Put a speculum and visualize the cervix with the aid of a speculum and thoroughly cleanse the cervix and vagina with a suitable antiseptic solution. So the cervix will look something like this from your speculum. Just clean it properly and grasp the upper lip of the cervix with a tenaculum or a suitable forceps like a valsellum. A valsellum or a tenaculum can be used. If the uterus is anterior lip, why we hold? Because we want to stabilize the uterus and a gentle traction will straighten the cavity. And if it is a retroverted, we grasp the posterior lip, we just open it and just a gentle traction and it becomes straight. Gentle traction on the holding forceps can be applied to straighten the cervical canal. Now what we are now like this. We are holding it with the forceps and we are gently going inside with a uterine sound. What is uterine sound? It is an instrument to measure the uterocervical length. We have done a PV examination, we had a sonography in our hand and now we see that what is the actual uterocervical length. Right? Now this is the sterile package which I was talking about earlier. And how does this LNG-IUS instrument look like? It looks like this. It has a handle. Threads are inside this, which is not visible once you open the package. There is a slider. There is a mark. There is an insertion tube. There is a flange. What is the flange? This how you can adjust the length of the inserter. And this is the LNG-IUS on the top, which is Mirena in this case. Now, how do we load? A simple procedure. There was a flange here and there was a slider here. So we pull the slider upwards so that what happens at the tip? Just have a look. Earlier, the horizontal arms were outside. Now, once we take the slider up, the tube goes up and the horizontal arms go like this and inside the tube, and now it is low. You cannot leave it. Once you load it, you cannot leave it. Now we have already measured from a sound what was our uterocervical length, something like this. So we have measured that this was the uterocervical length. So from the tip till the flange, we adjust the uterocervical length so that when the final insertion is done, the flange is at the level of the external os. Now, go inside the uterus 1.5 to 2 centimeter inside so that the tip is in the middle of the uterine cavity. Go there and now we will pull this slider somewhat back up to the mark. We will not completely release. Why? Because we have taken the horizontal arms inside, and once we will pull this thing back, the arms will open. We will give time for the arms to open. See, so 1.5 to 2 centimeter inside, and we pull this slider back, but only up to the mark, not till completely down. What happens? This tube comes partially back, so the horizontal arms now open again. And these horizontal arms take time to open. Count till 10 very slowly. 1, 2, 3. Let the arms to open. And then we will proceed like this. Then you proceed till your flange is at the level of external os, or you feel a small resistance that yes, we have reached the fundus. And now you pull the slider completely back to release the threads. Like this. Now you pull it completely down and then cut the threads around 1 to 2 centimeter from the level of the external os. Why we have kept this insertion technique here? Because it is a bit tricky and different from a simple IUCD insertion. Removal or replacement. Only thing what we need are preparation by telling the patient that what we are doing in a sterile area. We should have gloves, we should have speculum and a sterile forceps. It is just like removal of any intrauterine device. Just pull it gently out. Apply a speculum, catch hold of the threads and slowly pull it out. Applying gentle traction on the threads with the forceps. If the threads are not visible, what happens? These are simple Viva questions. Everything asked. What happens if there is no thread visible? Then go for ultrasound and determine the position of the LNG-IUS. If it is found in the uterine cavity, then remove it with a narrow forceps. See, it is very, very simple. It is inside the cavity, but the threads are rolled upwards. What will you do? You will tell the patient, give a small sedation, dilate the cervix a bit, and pull out with a narrow forceps. If it is not possible, then we can also go for a hysteroscopic removal of the same. Simple removal, just pull the threads out. Now, this is how we are going towards finishing. Now, these are the answers which the patient will ask. What menstrual changes do you expect once you keep inside the LNG-IUS successfully? Initial months, there is spotting and irregular bleeding. We don't know. It will spot, it will stop. It will bleed, it will stop. Because the changes on the endometrium, still it is under consideration that because it has an the atrophic changes start, so it becomes very fragile and the endometrium starts shedding irregularly for the first few months, probably 3 to 6 months. Then there is a progressive reduction in the menstrual blood loss and oligomenorrhea or amenorrhea. What is oligomenorrhea? This was an older term, that is infrequent bleeding in cases of where we have kept LNG-IUS, and sometimes it is complete amenorrhea. The patient is relieved of her problems, and that's why it improves iron deficiency anemia. It is highly efficacious. In more than 80% cases you can find that the iron deficiency anemia improves. Why? Because the loss stops. Frequency decreases, the amount of bleeding decreases, the pain decreases, the patient has a better quality of life, and iron deficiency anemia improves. What are the complications that we can expect? Expulsion, partial or complete. Fundal placement of the Mirena or the LNG-IUS is very important. During your insertion, if it was a fundal placement, that is the horizontal arms were in complete position, then if your patient selection was good, that is the uterine cavity was normal, the uterine size was normal, then the chances of expulsion are less. But if it was a big cavity and you just kept it like this without fundal placement, there are chances that with first menses, partial expulsion may occur. Uterine perforation may occur at the time of insertion. Pelvic inflammatory disease may flare up. And what is functional ovarian cyst? What happens initially, because you are supplying continuous progesterone and sometimes it is absorbed systemically also. So ovum may develop, but it may not develop completely. So a residual functional ovarian cyst is formed. So in cases of LNG-IUS, if you in sonography you find that there are some ovarian cysts, then they are bound to happen with LNG-IUS and then they settle with time. What warning and precautions you should tell to the patient? That in cases of migraine, you have to be very, very careful before inserting. Either don't do the insertion, otherwise be very, very careful. Focal migraine, any signs of transient cerebral ischemia. See, there are very less systemic side effects, but they are. There could be blood pressure rise, there could be some thromboembolic disorder in the brain. So any sort of asymmetrical visual loss or severe headache or marked increase in blood pressure, we have to be very careful in such cases and always look for such signs. Now, generally, what is the follow-up? We generally call the patient for follow-up 4 to 12 weeks after the insertion. 4 weeks means after the first menses is complete, to see whether the LNG-IUS is in place or not. If the patient cannot come after 4 weeks, then maximum up to 12 weeks. First follow-up visit should always be between 4 weeks to 12 weeks to be sure that the thing is placed in position and how the patient is like happy or not with the insertion, as well as with the outcome, whether there is irregular complaint to the patient. After this first visit, yearly checkup should be done in normal cases, and where otherwise needed, there are other medical complications, then frequent visits can be given, but first should be up to 4 to 12 weeks and then yearly. Now, what is about ectopic pregnancy? There are many questions that after insertion of LNG-IUS, the incidence of ectopic pregnancy increases. It is not like that. The overall pregnancy risk is very low, but if the pregnancy occurs, then it could be an ectopic pregnancy and the relative risk is high. That means in total, the rate of ectopic pregnancy is low because pregnancy rate is very low. But if the pregnancy occurs, then always rule out an ectopic pregnancy. What is the return of fertility? It returns rapidly after removal. If you remove it, it weans off very, very fast and the patient is ready to conceive again. And it does not cause permanent infertility. These are the most common questions asked by the patient. Now, some exam oriented key points which your Viva taker may ask: that it does not protect against the STI, it causes reduced menstrual bleeding over time, and the fundal placement is very, very important to prevent expulsion. This is all about LNG-IUS in today's lecture, and I hope now you are confident answering about LNG-IUS and giving it as a first option to your patient. Thank you.